presentation. Dr. Khalik is waiting, and it was a wonderful presentation by Dr. Azazman. So we are going to discuss a very common and important topic, urinary tract infections. But I'll try to be brief, as this is a common disease, and most of you are should be very experienced in this disease. Okay, the topic is important because it is so common that almost 40% of women, they report having a UTI at some point in their lives. To start with, we are going to categorize urinary tract infections under these categories. Acute uncomplicated cystitis in young women. This is the most common form of presentation. Recurrent cystitis in young women. Acute uncomplicated pyelonephritis in young women. Complicated UTI in men, and asymptomatic bacteriuria. Let's look at the algorithm so that you can have a map in your mind how you are going to approach the patient. Patient comes to you. The first question is this patient symptomatic? Symptomatic means urinary symptoms, dysuria, frequency, urgency. If the answer is no, and the patient has bacteriuria in the urine, she belongs to the category asymptomatic bacteriuria, which we'll discuss later. If she has a complicating factors, what are the complicating factors? We are going to discuss those too. If those are positive, then the patient comes under the category of complicated UTI. Does the patient have recurrent episodes? Yes, recurrent UTI. If none of these above, then you inquire about the symptoms of upper urinary tract involvement to exclude pyelonephritis. If the patient doesn't have all these symptoms, then either three of these: cystitis, urethritis, or vaginitis. UTI is very common in young women, especially who are sexually active, due to the following reasons. Number one is they have a short urethra, so that the ascending infection is easy. Sexual activity and trauma predisposes to the vaginal introital colonization, and then an ascending infection through the urethra. Behavioral patterns like delays in micturition, which acts as a flushing mechanism to flush off the uropathogens. Then their studies have shown that the use of diaphragm and spermicide as a means of contraception increases the risk of acquiring a urinary tract infection. Epidemiology, there was a Swedish study in which 7.8% of girls and 1.6% of boys entering school had a symptomatic UTI. And this declines as they enter into teenage, and when they assume sexual activity, then this incidence again rises. 50 to 60% of adult women report that they have a UTI at some point in their lives. This is a normal anatomy, as you all know. The pathogenesis is that the bacteria, the uropathogens, they arise from fecal flora. They colonize the introitus, and then they ascend through the urethra. Normally, only the distal urethra is colonized with bacteria, while the proximal urethra and bladder and upper urinary tract is sterile. So the infections involving this portion are called lower urinary tract infections, and the ureters and kidneys is called upper urinary tract infections. What's the microbiology in uncomplicated cystitis in young women? The most common cause is E. coli, and the other one is coagulase negative Staphylococcus saprophyticus, but only 5 to 10% have other Enterobacteriaceae or Enterococci as a causative organism. Now, how does the patient present? These are the symptoms. Number one is dysuria. Dysuria means pain, tingling during or after the urination. But this symptom is also present in urethritis, also present in vaginitis, and also may be present in upper urinary tract infections like pyelonephritis. So how we are going to differentiate, we'll discuss that later. Frequency, increased frequency of urination. Urgency, after the patient has finished micturition, the patient still feels desire to micturate. Hematuria, suprapubic pain, and foul smell of the urine. Now, how we are going to work this up? If the patient presents with dysuria, the first question is this cystitis, is this upper respiratory tract, urinary tract infection, urethritis or vaginitis? If there is a frequency or urgency along with dysuria, it signifies that patient may have cystitis or pyelonephritis. In urethritis and vaginitis, usually there is no frequency and urgency. Some cases of urethritis, especially with chlamydia, can have cystitis and they may present with urgency or frequency. But usually if there is only dysuria, look for urethritis or vaginitis as an explanation. The first thing to do is urinalysis. What we are looking is pyuria, pus cells in the urine. The normal limit is 0 to 4 in females per high power field. The other thing which you can do in the office is a dipstick examination. What you can do is it checks leukocyte esterase, which is an enzyme present in the white blood cells. So if this is positive, it has a pretty good sensitivity and specificity for the pus cells. So you don't have to do microscopy. You just do a dipstick. It is positive for leukocyte esterase, and if it is positive for nitrites also. Nitrites are formed by the Enterobacteriaceae by converting the nitrates into nitrites. So this is an indirect method that the bacteria are present in the urine. But there are some bacteria like Acinetobacter, Staph saprophyticus, which do not convert nitrate into nitrites. So it can be falsely negative. The other thing is hematuria. Urethritis and vaginitis usually doesn't cause hematuria. So if hematuria is present, it denotes that probably patient has a cystitis or upper urinary tract infection. The other thing is urine culture. There is a term called significant bacteriuria, which is more than 100,000 colony forming units of bacteria per ml of urine. As I told you earlier that the distal urethra is colonized with bacteria. So if a patient gives a sample of urine, there is a chance that these bacteria which are colonizing the distal urethra, they can cause a false positive urine culture. So how do we differentiate whether this positive urine culture is due to contamination or this is really true infection? So in the past there did studies in which in young female they did quantitative urine cultures, and they found that if the colony forming units are more than 100,000, then the chance of contamination is pretty low. So this is why they call significant bacteriuria. But now they found that the women who have dysuria and frequency but have lower colony forming units on urine culture, they still have infection. They did it by doing a suprapubic insertion. So this definition is no more valid in an uncomplicated young female. So in that case, the cutoff limit is 10 raised to power 2 or 100 colony forming units per ml. So the lab should give you the quantification, but the most labs usually they don't. They just on the report they say that urine culture positive and this is the bacteria. But ideally, it's the duty of microbiology lab to give you how many colony forming units of bacteria is present. This is a plate showing Staphylococcus saprophyticus in a culture plate, and you can see that it's more than 100,000 colonies. The way they do it is that they have a calibrated loop. They dip it in the urine and plate it. So that loop carries 0.001 ml of urine. So one colony represents 1,000. So if there are 100 colonies, so this one dot is 1,000 colonies. So if there are 100 colonies on the urine plate, this denotes that the bacteria are more than, the colonies are more than 100,000. This is a diagram, this is a picture of a slave castle in Cape Coast. And I just put it here because this is a urine canal just for the urine to go through. There are a lot of slaves in there, and this is in Ghana. This used to be in Ghana, in fact. Now the question is, young women with uncomplicated cystitis, should we do urine cultures? Now, the studies have shown that the causative organisms and their antimicrobial susceptibility profiles are predictable. Mostly it's E. coli or Staphylococcus saprophyticus. So if there are no complicating factors, what you can do is just give 3-day course of antibiotics and don't do urine culture unless other factors are present. And the other studies which have shown that in the other workup, IVP, ultrasonography, in this set of females have shown low rates of surgically correctable anatomic abnormalities. So there is no point in working those up with ultrasounds and other things. How do we treat these women? The question is, are we going to give a single dose versus 3 to 7 days of treatment? There were studies in which they show that the single dose is very effective, but later they found out that the rate of relapse is higher because single dose therapy fails to eradicate the carriage state in the rectum. So now you can treat it with single dose, but preferred treatment is at least 3 to 7 days of treatment with these following antibiotics. Quinolones are preferred because they are secreted in the urine in high quantity, and especially with the resistant pattern, quinolones are the preferable drugs. When should we do pre-therapy urine cultures? If there is a suspicion of having a complicated infection, or the symptoms are not characteristic of urine infection, or the persistent symptoms of UTI following treatment and you are going to start a new antibiotic, or the urinary symptoms recur, patient has a recurrence or relapse. Now, what is a complicated UTI? In simple terms, a complicated urinary tract infection, whether upper or lower, is associated with an underlying condition that increases the risk of failing therapy. For example, obstruction, urologic dysfunction, or you are suspecting a multi-drug resistant uropathogen. What is an uncomplicated urinary tract infection? When the patient presents to you, it's very hard to know whether the patient has a complicated infection or uncomplicated infection. So as a general rule, to simplify things, uncomplicated infection is defined as one occurring in a healthy, young, and non-pregnant female, and a complicated infection as one occurring in anyone else. So all other patients except this healthy, young, non-pregnant female always suspect a complicated infection, unless the workup denotes otherwise. These are the various factors which are present. If they are present in your patient, then you label it as a complicated UTI. Pregnant patients, advanced age, immunosuppression, recent urinary tract instrumentation or hospitalization, functional or anatomic abnormalities of the urinary tract, drug-resistant pathogens, diabetes, or chronic renal disease. So if a patient presents to you with cystitis or urinary infection, screen for complicated infection. Acute complicated cystitis. If a patient is present with cystitis who has the before mentioned risk factors, then it comes under the category of complicated infection. The patients with cystitis can have upper urinary tract involvement along with the lower urinary tract symptoms. In that case, fever, flank pain, and vomiting, they suggest that the upper tract is being involved. The bacteriology is different in the complicated infection. In uncomplicated, E. coli and Staph saprophyticus were the commoner causes. But here in complicated infection, the other enterobacteriaceae like Proteus, Klebsiella, Pseudomonas, Enterococci, Staphylococcus, yeast, they are more common. Pyuria is present in almost all patients, and urine culture should be done to find out the susceptibility pattern. Gram stain can be helpful. For example, if the gram stain of a spun urine shows gram-positive cocci, then Enterococcus could be involved, and in that case you can use ampicillin or amoxicillin. General principles of therapy: empiric therapy should be broad spectrum in this case, and treatment should be provided immediately. And the regimen should be tailored to a narrower spectrum as suggested by the susceptibility tests. How do you treat? Quinolones are again the first choice. One thing to remember is that sparfloxacin and moxifloxacin, they are less well secreted in the urine, so they are not used. Depending on the severity of infection, if you decide to give intravenous antibiotics, then ceftriaxone or other third generation cephalosporins or gentamicin once a day dose can be used. For enterococci, we have ampicillin or amoxicillin. The duration is usually 7 to 14 days, and the decision between 7 and 14 is mostly clinical. If there is no improvement in 24 to 48 hours, repeat urine culture and ultrasound to rule out obstructions. Routinely, we do follow-up cultures. Patient come with UTI, cystitis. We always order after a week of therapy that patient comes to you with repeat urine cultures. Most of the time, this is not necessary because if the patient does not have symptoms, even if he's having asymptomatic bacteriuria, except in few conditions, we don't treat that. We will discuss that down the road. Recurrent UTIs, very common in young women, and you have to really differentiate whether it's a relapse or it's a reinfection. And the reason is that for relapse, you have to work up for the complicated infection if the patient has any anatomic or physiological abnormality in the urinary tract. What's the definition of relapse? When the infected strain is the same and the recurrence occurs within 2 weeks of the completion of treatment. This is relapse. It means that your antibiotic treatment has failed to eradicate the original pathogen. What's a recurrence? Recurrence occurs after the urinary tract has been cleared after treatment. So reinfection occurs first, it occurs usually more than 2 weeks after the treatment, and the infecting pathogen is different from the original one. If it's the same pathogen and it occurs after 2 weeks, we call it again as a reinfection. What are the risk factors? Why do women get recurrent UTIs? There are some biologic or genetic factors. For example, some women secrete ABO antigens in their vaginal cells, and some are non-secretors. So the non-secretors have more risk of UTIs. Behavioral risk factors like frequency of sexual intercourse, voiding pattern, pelvic anatomy. Some female have shorter distance between the urethra and the anus. They are more prone for UTIs. Postmenopausal woman, as the atrophic vagina can harbinger uropathogens, and virulence determinants of uropathogens. For example, E. coli with P. fimbriated pyli causes more UTI. How do you treat recurrent UTIs? Again, short course, 3 to 5 days is enough. Either you can use Septron, trimethoprim-sulfamethoxazole, or amoxil, nitrofurantoin, ciprofloxacin. Macrobid is a nitrofurantoin. How do you prevent these infections? Number one is changes in behavior. Contraception. If a woman is using diaphragm or spermicide, stop using those. Post-coital voiding and liberal fluid intake, and prophylaxis with cranberry juice. Studies have shown that it inhibits E. coli from adhering to the urinary tract, but studies have still failed to prove that it treats a urine infection. So it is recommended in a dose. There are extracts available, imported extracts, 300 to 400 milligram tablets BID, or if the juice is available, 8 ounces TID. Other preventive measures, antimicrobial prophylaxis. Now there are 3 methods. One is continuous prophylaxis, which patient takes every day for 6 months. The other one is post-coital, for those patients who develop a UTI after sexual intercourse. And home antibiotics given to the patient to start as soon as the first symptoms appear. With continuous prophylaxis, usually we use small doses of nitrofurantoin, 50 milligrams OD, or trimethoprim-sulfamethoxazole, half double strength tablets every day or 3 times a week, or first generation cephalosporin. Same here in post-coital prophylaxis. Home antibiotics should be given to an educated patient who you are assured that patient will follow up with you. The question is development of antimicrobial resistance. Studies have shown that with low dose continuous prophylaxis, the chances of antimicrobial resistance are low. And in postmenopausal women, there are studies which have shown that estrogen cream intravaginally prevents recurrence of urinary tract infections. Urologic evaluation, usually in uncomplicated recurrent infections, unnecessary, but it is recommended if there is a suspicion about complicating factors such as structural or functional abnormalities. For example, if Proteus is isolated, which is usually associated with renal calculi, or patient has a relapsing infections. The reasons recurrent UTI occur is because the bacteriuria is failed to resolve, whether this is due to resistance or due to non-compliance, or bacterial persistence. There are some factors like renal calculi or chronic prostatitis, that's why the bacteria are persisting in the tract, or reinfection, that the original infection was clear, but now the patient is colonized in the vaginal introitus, and this is a reinfection. Acute uncomplicated pyelonephritis. It is less common than cystitis, and the presentation can vary widely from a mild illness to a life-threatening condition, and the pathogenesis is same as of cystitis. Microbiology is same as of uncomplicated cystitis, E. coli in 80 to 85% of cases, and Staph saprophyticus and Enterobacteriaceae. Features, as we discussed: flank pain, nausea, fever, CVA tenderness. So on exam you are looking for CVA tenderness, and it can occur in the absence as well as presence of cystitis symptoms, dysuria, frequency, urgency. Laboratory features: Pyuria Hematuria, and this is a systemic infection. That's why patients have leukocytosis with left shift and raised ESR or CRP. Urine cultures usually denote bacteria more than 100,000 colony forming units. Urine gram stain can be helpful for empiric treatment. And notice that the pregnancy should be ruled out. Now you have to make a decision to hospitalized. So indications for admissions are if patient is unable to maintain oral hydration and there are concerns about patient compliance or about the diagnosis, or the patient has a severe illness with fever, pain and marked debility. If the decision is made to treat as an outpatient, you can treat with oral antibiotics. The quinolones have the advantage of excellent bioavailability. So if you use quinolones orally and IV, there is not much difference in the bioavailability. Other antibiotics you can use is oral third generation cephalosporins or Septron if the pathogen comes back sensitive. Parenterally, you can use third generation cephalosporins. Duration is usually 7 to 14 days, and urologic evaluation indicated if there is no improvement in 72 hours or there are some other factors identified which are complicating the infection, or the patient has a relapse, or this is a second or more recurrence. Urinary tract infection in men. As we discussed, this is very common in women, but why it is so uncommon in men is because there is a less frequent colonization around the urethra because of the dry environment, and the length of urethra is more, and the prostatic fluid contains antibacterial substances that inhibit the uropathogens. So it is conventional to consider all UTIs in men as complicated. Bacteriology is same except that the Staph saprophyticus is a rare cause, and the principles of treatment are same as acute cystitis, except that we treat a little bit longer, 7 to 14 days. Chronic prostatitis should be ruled out in cases of recurrent cystitis, and all men with cystitis, they should be evaluated why this patient developed a urinary tract infection. Urologic evaluation probably not necessary in young healthy men without any other signs of complicating factors and a single episode of cystitis. But if they have a complicating factor or it is recurring, then the urologic evaluation should be done. Asymptomatic bacteriuria. This is a term which refers to the presence of a positive urine culture while the patient is totally asymptomatic. Now, what is the definition? Different in women and men, we have a different definition. In women, the bacteriuria should be confirmed by 2 consecutive midstream clean catch voided urine specimen, and the colony count should be more than 100,000 colony forming units. While in men, even if a single clean catch specimen grows 100,000 colonies, it comes under asymptomatic bacteriuria. If there is a catheterized specimen taken, then the threshold for labeling significant bacteriuria is 10 raised to power 2 colony forming units. Now, should we treat asymptomatic bacteriuria or not? There is no evidence that suggests that you treat asymptomatic bacteriuria and it is beneficial. So these categories we don't treat. Non-pregnant women, girls, men, diabetics, persons with spinal cord injury, or elderly patients, we don't treat asymptomatic bacteriuria. So what are the indications? In 2005, Infectious Disease Society of America published guidelines that these patients should be treated if they have asymptomatic bacteriuria. Pregnant women, because there is a risk of premature labor and low-term infants. So in the first trimester, they should be screened, and if positive, they should be treated. Before transurethral resection of the prostate, patient should be screened for asymptomatic bacteriuria. If positive, should be treated. Or other urologic procedures in which there is a chance that the mucosal bleeding might occur. How long do we treat? Usually 3 to 7 days. And then the periodic screening for recurrence bacteria should be undertaken after therapy. So once you have done the treatment, after a week or so, repeat the urine to make sure that the patient has eradicated the bacteriuria. Some people say that if the pregnant woman is still having asymptomatic bacteriuria, retreat it. And if it is still persistent, you give continuous low-dose therapy to prevent urine infections. UTI in children. It's a big topic. I didn't meant to discuss in detail, but so that just to remind you that the children can have UTI and they have devastating effects because their kidneys can become scarred, they can develop pyelonephritis and ultimately develop hypertension and chronic renal disease, and they may end up in dialysis. So that's why it's very important to identify urinary tract infection children, and these are usually the symptoms, how they present. But sometimes, especially very young children or infants, they present with urine infection or failure to thrive. So in that case, you should check urine to make sure they are not having an infection there. This is a flow diagram, and these are the common problems kids have. Voiding disorders or the voiding dysfunction, vesico-ureteric reflux or pyelonephritis. And if they are untreated, they lead to renal scarring, hypertension, and leads to end-stage renal disease. E. coli is the most common cause, and amoxil, first-generation cephalosporins, or second and third generation cephalosporins are used. We don't use quinolones as a prime treatment because data is still lacking that they might be harmful in young children. So to summarize, UTI is a pretty common disease, and many infections can be prevented and treated by appropriate interventions. Always choose a proper antibiotic and a proper duration, and identify the complicating factors and promptly refer for the further workup. And close follow-up should be done if they are treated as an outpatient to make sure that their symptoms have resolved. So I'm going to stop here, and if you have any questions, please ask.